prostate is one of the very important organ of male genital system. There are two diseases, surgical disease related, very important. One is a benign tumor known as BPH. Other is malignant tumor known as carcinoma of prostate. Let's start. Surgical anatomy of prostate. If you see a prostate, as it is a part of male reproductive system. Okay, prostate is a pyramidal shaped organ. If you see the normal function of prostate, it makes the volume of semen. Semen contains spermatozoa from testis, prostatic fluid from prostate, and seminal fluid from seminal vesicles. Okay, these are three major components of semen. So prostate provides a volume of semen as well as provide nutrition to the spermatozoa. This is the normal function of prostate. Okay, and you can see here the urethra that passes through the prostate is known as prostatic urethra. Prostatic urethra. If you see the composition of a prostate, then it is composed of three components: fibrous, smooth muscle, and glands. Okay, so you can say prostate is a fibro-musculo-glandular organ. The normal weight of a prostate in adult is around 20 gram. Okay, around 20 gram is an average normal weight of prostate. Two very important diseases that is related to prostate are BPH, cancer prostate. There's a cut section of prostate in a coronal section. What you can see over here is this is the urethra, prostatic urethra passing through the prostate. You can see there, and this is prostate. Okay, this is the prostate. Okay, so this is apex of prostate. This is base of prostate. Just at the end of the apex, you can see a muscle, which is known as external urethral splinter. In our urinary system, we have two splinters. One is internal, other is external splinter. Internal splinter is found at the bladder neck here as a round muscle, and external splinter is found at the apex of the prostate, near the apex of prostate here. These two splinters are very essential to control the urinary flow. Out of these two, the external splinter is very important, because if it is damaged, then you will not be able to control your maturation. The patient will not be able to control. So damage in external splinter lead to urinary incontinence. Okay, this anatomy is important. During the resection of prostate, that is TURP, that we do for BPH, it's a very common surgical procedure. So during that process, we have to always take care of splinter, because we should not injure the splinter such that after surgery, patient will have incontinence. When we do TURP, so we will not be able to see these splinter. That's why we should know the surgical landmark. See this elevated part, this one. This elevated part is known as verumontanum. Okay, in short, we just say veru. So this is an elevated part in the posterior part of the prostatic urethra. Just below that, you can see there is a splinter. We don't resect below or distal to verumontanum. We only resect at this part. So we don't disturb veru, because once you resect distal to veru, there's a very high chance of damaging splinter urethra. This verumontanum is a landmark, surgical landmark, to identify external urethral splinter. Anatomically, the prostate is divided into 5 lobes. So this is prostate. See, okay. Prostate contains prostatic urethra, which lies slightly anteriorly, not exactly at the middle part, okay, like this. And one more thing, the vast difference, okay, and the seminal vesicle, these two joins to form a duct known as ejaculatory duct. So this is vas carries spermatozoa from testis, and these seminal vesicles, they produce seminal fluid. So spermatozoa and seminal fluid get mixed and come to the urethra, and then prostatic fluid get mixed, and at the end it forms semen. These two landmark, one is this urethra and this is ejaculatory duct. So part of prostate that lies anterior to the urethra is known as anterior lobe. That lies posterior is known as posterior lobe. The part of urethra that lies above this ejaculatory duct, this is known as median lobe. And obviously this is a side view, so there is a lateral lobe, two lateral lobes. Okay, so let us cut this part and see the cross section. You can see over here, this is prostatic urethra. That lies anterior is known as anterior lobe. That lies lateral is known as lateral lobes. That lies posterior is posterior lobe. And the part of prostate that lies in between the two ejaculatory duct, this is median lobe. Okay, so prostate is divided anatomically into 5 lobes, 2 laterals, anterior posterior, and median lobes. So during cystoscopy also we see whether the 2 lateral lobes are enlarged or not, whether there's median lobe enlargement or not. So we can see that. But but nowadays we use a zonal anatomy, zones of prostate. Okay, so depending on the different glandular patterns, we divide the prostate into 4 zones. This is more important than the anatomical lobes. Okay, let's see. This is urethra. This is a 3-dimensional picture. Okay, you can see here, this is urethra. Okay. The part of prostate that surround the urethra, see this one, the tissue of the prostate that surround the urethra, prostatic urethra, this is known as transition zone. The part of prostate that lies between 2 ejaculatory duct, this is known as central zone. The part of prostate that is now like surrounding the entire prostate, remaining these 2 parts, except this 2 part, that is the laterally, posteriorly. Okay, this huge area is known as peripheral zone. And a part of prostate that lies anteriorly, just anteriorly, and composed of muscles and fibers, not gland, this is known as anterior zone. Transverse section. So this is the image. This is urethra, you can see. The part of prostate that surround the urethra, this one is known as transition zone. The part of prostate that lies anteriorly and having no gland, just fibrous and muscular part, this one is known as anterior zone or anterior area. Okay, so part of prostate that lies between 2 ejaculatory duct is known as central zone, and the remaining all the area, okay, that is covering the anterior to lateral to posterior entire area is known as peripheral zone. The glandular distribution in these zones are different. That's why depending on the glandular pattern, gland distribution, it is divided into 4 zones. Okay, so transition zone, central zone, peripheral zone, and anterior fibromuscular area. BPH is a benign prostatic hyperplasia. You can say benign enlargement of prostate, a benign disease that occurs mainly in transition zone. Okay, and the cancer prostate mainly occurs in peripheral zone. So see, that's why the zonal anatomy is important. And when you know this anatomy, and you'll be able to explain why in BPH patient develops LUTS or obstructive feature, very common, because see, it is very near to the urethra. Once the prostate enlarge, they start to compress the urethra, right? That's why the BPH will produce feature of bladder outer obstruction very normally, easily. But if you see a prostate cancer, the cancer has to spread, then involve the urethra. So that's why if a patient of cancer prostate present to you with a BOO, it is already a late disease. So I'm not saying BPH only occurs in transition zone, mostly occurs in transition zone, but also it can occur in other zones. The cancer prostate mainly occurs in peripheral zone. That doesn't mean it won't occur in other area. Okay, I'm saying most commonly. Okay, capsules of prostate. This is important. Let me explain. There's a true capsule. True capsule means it is the outermost layer of a prostate gland made up of fibrous tissue. Okay, this is what a true capsule means. What is false capsule? Just outside the prostate, there's a outside the prostate there's a layer of a fatty tissue. There's a layer of fatty tissue. This fatty tissue is known as false capsule. False capsule. Okay. In between the true and false capsule, we have prostatic venous plexus. This is important. Remember that. These venous plexus, this lies outside the true capsule. Why it is important? Whenever we do TURP here, we try to resect the prostate, and while doing that, we go deeper and deeper and deeper, and we don't want to disturb this capsule. Okay, because once you disturb the capsule, you are just going to injure the plexus, venous plexus. And when the venous plexus is injured, there will be a massive bleeding, which is very difficult to control. So during the section, once we reach the capsule layer, we just stop the resection at that point, and then we start resecting other areas. In between the rectum and the prostate, there is a fascia known as Denon-Wheeler fascia. This is a fibrofatty fascia. The cancer prostate, due to these Denon-Wheeler fascia, the spread to rectum is very late, not that easy. It can spread to the bladder wall, neck. It can spread to surrounding other organs, but the spread to rectum is somewhat prevented by this Denon-Wheeler fascia. That's why rectal involvement in cancer prostate is a late feature. The area of the prostate that lies around the urethra, this is known as transition zone. This is transition zone. Okay, and when there is a BPH, this zone will get enlarged. Okay, enlarged. It enlarges in such a way that it compresses the peripheral zone. So this is peripheral zone. So see here, the peripheral zone is compressed by enlarging transition zone. Initially, the peripheral zone was like quite big, but due to enlargement of a transition zone, now it become very small. See, the compressed. This is a compressed peripheral zone. This compressed peripheral zone, this one is known as surgical capsule. During a open prostatectomy surgery, I'll teach you later on. So when we open this capsule, and once we reach at that surgical capsule, once we open it, so we can introduce our finger through here, this gap, and we can easily remove this lobe by our finger. Just a finger can easily peel out that enlarged prostate. Okay, why it is possible? It is only possible because of that surgical plane provided by compressed peripheral zone. So inferior vesicular artery is the main artery for prostate, which is a branch of internal iliac artery, and it supplies the bladder and prostate. Okay, you can see the distribution. These artery has a major branch at 5 o'clock, 7 o'clock positions. So during the section of the prostate, we know the positions where the artery is situated, and while dissecting those area, we'll be very, very careful, and we always coagulate the bleeding site. Okay. Beside that, it also gets supplied from middle rectal artery and internal pudendal artery. This is prostate. This is true capsule. This is false capsule. So we know just outside the prostatic capsule, there are a lot of veins of venous plexus, right? So see here in this picture. So these are the venous plexus around the prostate. And normally the blood from prostate go back to internal iliac vein, then to the common iliac to inferior vena cava, and from inferior vena cava, obviously it goes to the heart, right? Heart. From heart, it goes to all the organs. And the first organ to get is lung. But there is exception in prostate. The exception is it has dual communication. One is this is the normal pathway I've shown you. These prostatic venous plexus are communicated to the vertebral vein via a vein known as Batson vein. Batson vein, okay, Batson. So Batson vein is a valveless vein that communicate the prostatic venous plexus to the vertebral venous plexus. So the prostate cancer can follow this alternative route and directly invade the vertebra. That's why in cancer prostate, the most common site of metastasis is bone, not the lung. As a rule, lung should be the first site of metastasis because whenever there is a cancer in a systemic circulation, the cancer goes to lung first. But here, as there is an additional communication between the vertebral venous plexus and prostatic venous plexus via a valveless vein, Batson vein, which allows the prostatic cancer cell to go to vertebra first. That's why the vertebral metastasis is the most common site of metastasis in cancer prostate, then lung. So there are two pathways. One goes to inferior vena cava, and other goes to vertebral venous plexus via Batson vein. So remember that, okay? Fine. Inferior vesicular artery is the main artery for prostate. Yes, the verumontanum is a landmark for external splinter. A is the answer, correct. This is the most common cause of benign tumor in men, okay? And this is age related. Usually common after 50, so 50 to 60 years group, that's a very common age group for BPH. And once the patient survive for like 60, 70, 80, 90, then the longer they go, there's a higher chance of getting BPH. BPH is one of the very common cause of LUTS in male. So if you remember that LUTS lecture, so see, this is bladder. This is urethra. Okay. Any cause of obstruction from the neck of the bladder to distal part, okay, from the neck of the bladder to distal part is known as bladder outer obstruction, and the common causes are BPH, enlarged prostate, that is BPH. Cancer prostate can cause, but not that commonly than BPH. Okay, cancer can invade the urethra. There could be a congenital valve. There could be stricture urethra, narrowing of urethra, stricture urethra, stricture urethra. There could be phimosis, narrowing of prepuce. Okay, these are the common cause of bladder artery obstruction in male. So, so among these cause of bladder artery obstruction, the most common cause is BPH in elderly male. Whenever there is a bladder artery obstruction, then it produces some features, and that that known as LUTS. Why? Increasing age is a risk factor for BPH. Okay, that's a very interesting thing to understand. We have a lot of theories that try to explain why the BPH occurs. Somebody has explained as a neoplastic theory, that is, it is just like other tumors, BPH, benign tumor. But most accepted theory is hormonal imbalance theory or hormonal theory. What is that? Let me explain. Okay, as you know, the male hormone is testosterone, secreted by testis, right? And this is converted to dihydrotestosterone. Testosterone. In short, we say dihydro DST by the enzyme known as 5-alpha reductase. This occurs at the peripheral tissue, that is at the prostate. And this dihydrotestosterone, what does it do is it provide, that influence for the growth of prostate. So prostate growth is maintained by this dihydrotestosterone. How? Obviously, this DST has receptors in the prostate, acts in these receptors and maintain the growth of prostate. So this is a normal process. Okay, male has testosterone, no doubt, right? This is the main hormone in male, but male also contains very little amount of estrogen. Estrogen is the main hormone for female. We know that, right? But in male also, estrogen is produced by adrenal gland of male. When the male is adult, the testosterone level is always high, right? Because the testis is functioning well and producing the testosterone. But once the age increase, once this age is increasing, what happens is the level of testosterone is decreased. Okay? Estrogen remains same, but the testosterone levels start to decrease. Let me give an example. In a male has, suppose a male testis secretes around 100 testosterone and just 10 estrogen by adrenal gland per day. At the age increasing at the age of 60, 70, now the testis is secreting only 50 testosterone per day, but estrogen is same. So now we can say, if you compare now, the estrogen level is comparatively increased. Why? Because initially it was 10:100, now it is 10:50. And what does it do? They increase the receptor number in prostate. Now even though, see here, even though there are less testosterone, but the activity increase because of increased receptors. So you can say, in old days, due to increase in the number of receptor, even though the testosterone number is decreased, the activity of testosterone increased, such that at the old age, the prostate size gradually increase. If you just think normally, okay, fine, old age testosterone should decrease. So once the testosterone decrease, dihydrotestosterone also decrease, then prostate size should shrink, not increase. But the problem is the testosterone estrogen ratio. Here in the old age, the ratio is altered, estrogen is comparatively increased, causing increased number of receptors of prostatic gland, and then increasing the activity of DHT, causing gradual enlargement of prostatic gland. So this is the acceptable theory for BPH. Everything I've explained is here in slide. Okay. So, see, Whatever zone you take, except this anterior fibromuscular area, all this area has a combination of three structure, that is gland, okay, muscle, smooth muscle, and fiber. See, whenever a patient of BPH come to you, they may have a various kind of clinical feature. That is, sometimes a patient of BPH, that is enlarged prostate, will not have any symptoms, just BPH. The gland was enlarged, but no symptoms are seen. But mostly the patient of BPH will have symptoms, that is LUTS. See this one. So a patient of BPH will have LUTS symptoms known as lower urinary tract symptoms. I'll explain in detail. Wait. Sometimes patient of BPH may have feature of complications, or sometimes you'll get a patient having all the features, BPH with LUTS and with complications of bladder outlet obstruction as well. Let me explain one thing. See, this is bladder. Okay, this is prostate. Okay, and you can see here, I already told you that the prostate comprises fibromusculoglandular glands, fibers, and muscles. Usually, the fibers and muscles are found slightly along the capsule, and also around the urethra also. And obviously, remaining entire area contains gland. Okay, glandular area is more found centrally. So if there's an hyperplasia, that is BPH, then any one of this component can get hyperplastic. Okay, if a gland become enlarged, then it obstruct the flow. So obstruction of flow by gland enlargement is known as mechanical. Mechanical means it is really obstructing the flow mechanically. If the BPH contains more of these fibromuscular tissue, then it lead to dynamic obstruction. If you can make this muscle relax, then the urinary flow become very good. That's why there are some drugs known as alpha blockers, which relaxes smooth muscles, such that the dynamic obstruction is relaxed. That's why patient has very rapid symptomatic control. But to decrease the mechanical obstruction that is caused by glandular hyperplasia, we have to give a drug that will reduce the size of prostate. That is known as
5-alpha reductase inhibitor.
these are the drugs we use. Okay, I'll explain later on again. So to reduce the mechanical obstruction, we have to give a drug that decrease the size of prostate. And the effect of BPH is complications. Okay, complications of BPH. So just imagine a prostate is enlarged here. Okay, causing that mechanical and dynamic obstruction. So it is causing bladder outlet obstruction. That is, the urine is not going out. That means there is stasis in urine. That is, patient is unable to evacuate all the urine. Some urine will stay there. Stasis lead to infection. We know that. Stasis lead to stone formation. And when the stasis is there for a longer time, and that the urine volume that remains inside the bladder is more than 100 or 200 ml, then it start causing reflux, because the bladder tries to push these remaining urine, okay, badly, and it increases the pressure a lot inside the bladder, causes reflux of urine. And what does reflux do? Reflux causes hydroureteronephrosis and can lead to chronic kidney disease, kidney damage. Okay, and the surface of these prostate, enlarged prostate, has enlarged vessels, and that can rupture time to time, causing hematuria. So hematuria is not a common feature of a BPH. Rather, it's a part of complication. So BPH can cause UTI. BPH can cause stone formation, bilateral hydroureter nephrosis. Due to reflux, there may be hematuria, and as I've already told you, the bladder contracts a lot to push that urine out of the bladder, it may lead to diverticula. Diverticula means outpouching of the mucosa. The mucosa may outpouch due to the pressure, increased pressure. This is known as diverticula. These are the complications that is related to BPH if not treated for a longer time. Yeah, one thing I have to explain. Wait. See, a patient with BPH will have a gradual, problem in micturition. Sometimes they present to you with an acute retention of urine. That means the patient will be unable to pass urine suddenly. How it is possible? It is usually if the patient of BPH took a lot of water and the bladder is unable to contract, or if there's a UTI, then there'll be edema. Certain edema causes acute retention. Mostly they present to you with a chronic retention. Whenever the patient is unable to completely evacuate, and if some urine remains inside the bladder, okay, that is what known as chronic retention. There is a slow retention of urine going on. Patient will be able to pass urine, no doubt, but he will be not able to evacuate the bladder completely. This is chronic retention.
Let us discuss about low urine tract symptoms. Previously, it was called as prostatism because the prostate BPH is one of the most common cause of LUTS. That's why it was named as prostatism. But you know that there are so many causes that can produce these symptoms like BPH, cancer prostate, bladder neck hypertrophy, stricture urethra, uh, cystitis, and so on. We don't use term prostatism nowadays. Rather, we say LUTS. So LUTS is actually non-specific symptoms of bladder dysfunction, which is due to either bladder outlet obstruction or inflammatory disease of bladder. So LUTS has basically two distinct type of symptoms. It could be obstructive symptom, obstructive symptoms, also known as voiding symptoms. Okay. Other is irritative symptom, also known as storage symptom. Let me explain these symptoms in relation to BPH as we are studying BPH. That's why. But don't forget that these symptoms are not only produced by BPH but also by other disease. Okay. Bladder. Okay. So patient will have obstructive feature like hesitancy. Hesitancy means there's a delay in the start of micturition. Patient will go to washroom. Normally within few seconds the micturition should start, but in the case of BPH due to obstruction, it takes time to start. This is known as hesitancy. Intermittency. Intermittency means it is a involuntary starting and stopping of micturition. That means when the patient start to micturate and involuntarily the urinary stream will slow down and it will stop. Again patient will strain and they start micturition again. So involuntarily stopping and starting micturition is known as intermittency. Poor flow. Poor flow means it is a progressive loss of force of urine. Not only force and caliber both. So suppose this is penis. Okay. Patient will have very good flow previously. Okay, and they gradually start developing very narrow flow. Straining. Straining means patient will start to contract lower abdominal muscles. They gain some good urinary flow. So this is known as straining. sense of incomplete void. That means even when the patient finishes his micturition, he feels that there is urine still remaining inside the bladder. It is known as sense of incomplete voiding. There are other there are other obstetric features as well, like post void dribbling. That means after micturition, patient feels that some drop of urine fell down into his undergarment. That is, terminal release of drops of urine at the end of micturition is known as post void dribbling. Patient also may complain of acute retention of urine, which is defined as sudden inability to pass urine, and the patient experiences very strong agonizing lower abdominal pain, which is associated with severe urgency. Patient tries to pass urine, but they fails. Sometimes a few drops of urine may come out, but they fail to pass urine. This is known as acute retention of urine. These are the obstructive features. Okay, out of which these four, please remember these four IPSS. Now, whenever there is obstruction of urinary flow, the muscle, the muscle of bladder is known as detrusor muscle. This muscle start to contract. Okay, start to contract, and this obstruction lead to irritation of bladder muscle. No, that causes frequent contraction of bladder muscle, and you know what happened after frequent contraction? The patient will have frequent urge to pass urine. Okay, so due to obstruction, the muscles of bladder irritated, causing frequent contraction and leading to symptom complex known as storage symptoms or irritative symptoms. What are those? Frequency. Normally adult void around 5 to 6 times a day with the average volume of 250 to 300 ml of urine per void. But in the case of BPH, the patient micturate multiple times a day, and the gap between two micturations is less than 2 hours. Obviously, it is due to irritation and contraction of the smooth muscles of bladder, right? Nocturia. Nocturia means frequency at night. That is, patient has to wake up at the night to pass urine. This is known as nocturia. Urgency. You can remember as FUN, okay, sequence that way. Urgency means a strong, sudden desire to micturate. This is known as urgency. And dysuria. Dysuria means painful micturation. Normally, dysuria occurs when there is an acute inflammation of bladder, urethra, or prostate. So, due to obstruction, it is very commonly associated with infection. So, obstruction lead to infection, and that lead to dysuria. You should remember these seven: frequency, urgency, nocturia, intermittency, poor flow, straining, and sense of incomplete voiding. So, by using these seven symptoms, we have a scoring system known as IPSS scoring system. And this scoring system allows us to classify the patient as mild symptoms, moderate symptoms, and severe symptoms. Wait, I'll explain.
Whenever we get a patient with BPH, we ask question related to this seven point. Okay, this is frequency, urgency, nocturia, okay, intermittency, poor flow means weak stream, straining, sense of incomplete voiding. Each symptom has total 5 scores. Maximum score is 5, minimum score is 0. So there are 7. So the maximum score is 35, minimum score is 0. So we give the scoring and then we evaluate. If the score is between 0 to 7, then we say it's a mild disease, a mild symptom. If it is 8 to 19, then we say moderate symptoms. If it is more than 20, that 19, that is 20 to 35, then severe. So mild, moderate, severe. We classify that way. Why we need to classify? See, number one, suppose a patient come to you and you evaluated the patient and you found the symptom was suppose 22. Okay, and you have started drugs, and after 6 months he came and you have again evaluated him and you found the symptom to be score to be 12. Now you can say to see your symptom was in severe condition, now it is in moderate condition. So if you continue the medication, it is working. And if the score become like 30, then you say the drug is not working now. Now let us plan for surgery. So this scoring system give us idea what medication should we start or what treatments we should start, and it helps us to evaluate patient during follow-up. Should I continue same treatment or should I change? For you, I don't suggest to remember this chart. So the most common site of BPH is transition zone. The most common site of cancer prostate is peripheral zone. Don't forget this one. Most commonly at this one, say prostate. It's a very common question, okay? Don't forget. This picture will explain. Median lobe. The median lobe is very near to the bladder neck. You can see here. So any lobe enlargement can cause obstruction, but mainly if the median lobe enlarges, the lobe will go into the bladder, obstructing the neck. See, the neck is obstructed. See,